Hi and welcome to Abnormal Psychology Online. I'm Steve Miller and I'll be your instructor for the entire semester. So what I want you to consider is, most people would agree that a mother who throws herself in front of a train while holding on to her young child is not behaving normally. But how do we distinguish between someone who is temporarily unable to get out of bed in the morning because they're going through a traumatic divorce, and that compared to someone who was just suffering from severe depression? Today, you've gotten out of bed, you had breakfast, you went and got dressed, you went to class, you studied a bit, and then at the end of the day you enjoyed some of the company of your friends before falling to sleep at night. It probably didn't occur to you that many physically healthy people are unable to do some or any of those things. So what they may have in common is a psychological disorder or psychological dysfunction, with an individual that is associated with distress or an impairment in functioning and in response, and the response is not a typical or culturally expected one. So how can we know whether the behavior is normal or abnormal? At what point does our fear, our thoughts, our moods, changes, and actions move from the normal range to the mentally disturbed range? We're going to explore the many different psychological disorders, their symptoms, and some of the possible causes. And so what we're going to do in this first thing is to ask the obvious question: what's abnormal and what is abnormal psychology? So that will be what we'll do in this first segment. Now what I'm going to do here now, and I will mention it several times throughout the semester, it's really very important. This is the same message I got from my abnormal psychology professor in university, is that nobody taking an abnormal psychology class should self-diagnose. You're not professional, you're not skilled, you're not studied enough in the area of and don't know what the DSM-5 contains in order to make a proper diagnosis. Irregardless, one does not self-diagnose. And so it's important that even though there will be some elements of behaviors or thoughts that you might have from time to time, the difference is the frequency, the duration, the intensity, the longevity, and not having that set of balance that maybe you and I might have, where I might be sad from time to time, I'm not depressed. And if I had concerns about whether or not I was, it would be most important to go to a psychologist, a psychiatrist, a doctor at least, to do the initial stages of finding out whether or not it was just malaise, somewhat of a sadness that's carrying on because I'm grieving, or whether it's something a little more clinical, but that's not something we decide for ourselves. All right? So let's go and look at what is abnormal and what is abnormal psychology.
Abnormal psychology is the branch of the science of psychology that addresses the description, the causes, and the treatment of abnormal behavior patterns. Now, there will be various criteria are used to define abnormal behavior. Psychologists generally consider the behavior as being Various criteria are used to define abnormal behavior. Psychologists generally consider behavior as being abnormal when it meets some combinations of the following criteria. When we think about, how to define abnormal behavior, there's some questions that we can ask. One, is the behavior unusual or is it infrequent? Does the behavior violate social norms? Is it something that is socially unacceptable or in violation of social norms? Does the behavior involve faulty interpretation of reality? Now, by way of an example, I personally am a kind of an example of what people often say is abnormal. I wear shorts in the winter all year round. Now, if you look at it and say, well, is the behavior unusual? You'd say, it probably is unusual. Not very many people do it. Does the behavior violate social norms? Well, it does. Most people dress appropriately or what they would define as appropriately for the weather, and shorts isn't it. Does the behavior involve faulty interpretation of reality? Well, I know that it's winter. I know that people wear, long pants and dress warmly for the winter. It's not that I interpret reality differently from everybody else. I just find wearing shorts not uncomfortable in the winter. And if we carry that thought along, we can continue to ask some questions, and they could include, does the behavior cause personal distress? Well, in my instance, the behavior does not cause personal distress. But in some people's circumstances, people who are depressed or go through different other sorts of psychological disorders will find that some of the behaviors that they participate in are behaviors that do cause them distress. Is the behavior maladaptive, or is it self-defeating? That's another condition which, in my instance, doesn't apply. And lastly, is the behavior dangerous to the person or to others? And so these are the kinds of things that we think about when considering, is a behavior abnormal or not? Now, there are other factors that affect our perception of what is abnormal. The determination of which behavior patterns are deemed as abnormal depends on cultural beliefs and the expectations of that culture. Concepts of health and of illness may also be different in different cultures. Abnormal behavior patterns may take different forms in different cultures, and societal views of abnormal behavior may vary across cultures. Behavior considered normal in one culture may be deemed abnormal in another. For example, how anxiety or depression is expressed or accepted within different cultures. We may consider how people in different cultures express states of emotional distress, including depression and anxiety, rather than imposing our perspective on them. Failure to recognize cultural differences in what is deemed normal and abnormal can lead to inadequate and inappropriate diagnosis and treatment. Another factor that could be influencing what is perceived as abnormal is context. Now, is this picture abnormal? Well, if you're celebrating the success of a Canadian team and you're out celebrating and you're in the stands, and you might want to say, hey, we're Canadian, this might not be seen as inappropriate. But if you're at church, this might be seen as inappropriate or abnormal. The context has shifted. Does it deviate from social norms? That depends on where and when the behavior and the attire occur. Can you think of any other factors that might affect our perception of what is abnormal behavior? Now, one of the other reasons that we should study abnormal behavior is that it affects virtually everyone in one way or another. Either we ourselves experience abnormal behavior or a psychological disorder, or we know somebody who does, whether it be family or friends. Abnormal behavior patterns that involve a disturbance in psychological functioning or behavior are classified as psychological disorders. 20% of Canadians will suffer from psychological disorders sometime in their lifetime. Now, how common are psychological disorders? Well, anxiety disorders, about 30% of adults in their lifetime will experience an anxiety disorder. Mood disorders, 20% of adults in their lifetime. Substance abuse disorders affect about 15%. And any disorder at all, about 46% of all adults will experience some sort of dysfunction in their lifetime. So what are some of the risk factors that could contribute to developing a psychological disorder? And again, I will emphasize here, just because some of these things you may fit within the category doesn't make it likely that you will necessarily have a psychological disorder. So let's make sure we don't personalize some of what we get out of this course. Now, in a major Canadian study of psychological health, Stephen Dulberg and Joubert determined that key risk factors include age, education, childhood traumas, current stress, life events, social supports, gender, and physical health. Now, resilience is is a term that's used to describe the display of positive adaptation in the face of adversity. And so those people with greater resilience find themselves being less susceptible to some adversities. It's the capacity to bounce back from our lows and learn learn from them in a positive way. It's vital sense of flexibility and the capacity to reestablish one's own balance. So resilience is one of the things that we use to combat these sort of shifts and changes in our lifetime. When morbidity and mortality issues are factored into the question, poor mental health is one of the costliest health concerns and considerations in Canada, with the conservative estimate cost in the neighborhood of 14 billion, that's with a B, dollars annually. So what are the risk factors for developing psychological disorder? Well, exposure to multiple risks can have an exponential effect on that dramatically increase the likelihood of adverse outcomes. Exposure to just 2 risks can engender a 4-fold increase in adverse outcomes. Exposure to 4 risks, 4 or more, can increase adverse outcomes 10-fold. So the risk factors are not something that are necessarily unusual. It has a lot to do with our degree of resilience, hardiness, and other factors that can contribute to whether or not it'll impact us in a negative way. So let's look in terms of historically, where we've come from to where we are in terms of how have we handled psychological and abnormal behavior. Ancient societies attributed abnormal behavior to divine or supernatural forces, known as demonological model. Stone Age skulls have shown that our prehistoric ancestors practiced turfing. This is where they would cut a hole in the person's skull, possibly as a means of releasing demons. There were some authorities in ancient times, such as the Greek physician Hippocrates and Galen, who believed that abnormal behavior reflected natural causes. Hippocrates, for example, proposed that abnormal behavior was due to an imbalance in humors, vital fluids. One was known as phlegm, a second as black bile, third blood, and fourth yellow bile. The importance of this theory was that it foreshadowed the development of the modern medical model of abnormal behavior, by which disorder and disease are seen as resulting from underlying biological processes. So even though this is going back many, many years, there's still links to how this helps with how we describe abnormal behavior today. Now, if we carry on through medieval times, in the Middle Ages, we saw a return to the doctrine of possession, revitalized by the Roman Catholic Church. Exorcisms became a common practice to expel evil spirits or demons from affecting individuals. Later, beginning in the 15th century, people who displayed abnormal behavior were considered witches. Now, if we carry on with our history, the asylums that were established in Europe in the New World, asylums, or as they were also known, madhouses, began to crop up throughout Europe in the late 15th century and early 16th centuries, often on the site of former leprosariums. This is where people with leprosy were kept. The conditions in these asylums were dreadful, and in some, such as the Bethlehem Hospital in England, it became somewhat of a circus atmosphere where people would come by and be viewed because of their unusual behavior. With the rise of moral therapy in the 19th century, largely spearheaded by Frenchmen Jean-Baptiste Poussin and Philippe Pinel, conditions in the mental hospitals improved. Proponents for moral therapy believed that mental patients could be restored to functioning if they were treated with dignity and understanding. The decline of moral therapy in the latter part of the 19th century led to a period of apathy, and to the belief that the insane could not be successfully treated. Conditions in mental hospitals deteriorated and offered little more than custodial care. Moral therapy had little to do with the ethical code. Rather, it emphasized treating institutional patients as normally as possible and allowing them the opportunity to interact with normal settings. It emphasized learning from social norms. At the same time, that massive immigration in North America was taking place, Canadian activist Dorothea Dix Crusade began to speak out about the conditions in asylums. Appalled by the poor standards in asylums, and she began what became known as mental hygiene movement. Unforeseen result was that more patients were taken out of jail and admitted to asylums. Overpopulations led to decline of the moral therapy use. Not until the middle of the 20th century did public outrage and concern about the plight of mental patients mobilize legislative efforts towards the development of community mental health centers as alternatives to long-term hospitalization. The Canadian Mental Health Association began in 1963. This moved towards a movement called deinstitutionalization, which spurred by the introduction of psychoactive drugs called phenothiazines, which curbed more flagrant features of schizophrenia. So deinstitutionalization in Canada has resulted in many homeless individuals with mental health issues who got lost in the transition from psychiatric institutionalization to largely inadequate community mental health services. This was a very big concern in Toronto, and a very popular, very big downtown psychiatric institution released people, and the streets became filled with homeless people with psychiatric concerns. In 2007, the federal government announced funding for the Canadian Mental Health Commission in order to implement a national healthcare strategy.
Now, what we're going to be looking at next week will be just what's on the slide here, and that would be looking at more current perspectives about abnormal behavior. What we've looked at has been somewhat the past and where we've been and what led us to where we are today. But we're going to look at the biological perspectives about abnormal behavior. We're going to look at the psychological. We're going to look at the socio-cultural. And we're going to look at interactionalist perspective. So this will take up the remainder of the chapter. This is part 2 that we're going to be starting then. And so that will be the next video that you'll find in week 1. All right. Hope this is going to be okay for you. If you've got any questions, please email or text me or stop me in the hall when you see me. Again, I'm the one that's wearing the shorts and even in the wintertime. Bye now.